Hello, I'm Dr. John Kruse, and welcome to today's question and answer session. So this is a time to pose your questions about ADHD, other mental health topics, and there are 3 videos that I released in the last week that can be jumping off points, but we're not limited to those topics. I should put a reminder in that this video and all my videos are for general informational purposes only. So although I am a psychiatrist and have training as a neuroscientist, you should take anything I say with a grain of salt and consult with your own physician teams, people who know you well, before acting on anything that I say here. So the 3 videos that came out this week, one was a new release that was on glutamate and ADHD. Glutamate is far and away the most abundant neurotransmitter in the brain, although many people only know about it through its association with being a food flavoring as monosodium glutamate. In a really oversimplified way, glutamate and dopamine in some areas of the brain at least have a reciprocal interaction. And by that I mean when glutamate's high, dopamine's low. When dopamine's high, glutamate's low. So one way of boosting dopamine, which seems to be helpful in ADHD in some parts of the brain, would be to inhibit or block glutamate. And we do have some drugs that are glutamate blockers. And there's some fairly preliminary evidence that memantine, an NMDA receptor blocker, can help with ADHD. But in general, the system is so abundant and so complex that it's going to be challenging to develop good glutamate-acting drugs to be of help with ADHD or with other mental health conditions. Second video, this was a sound redo on this. So this is an older video, was titled, Why is there no cure for ADHD? And this is sort of taking aim at the older views that ADHD is just about low dopamine or messing with neurotransmitters. And absolutely, there's convincing, solid evidence that messing with transmitters, particularly dopamine and norepinephrine, can reduce ADHD symptoms, but it isn't curative because the issues underlying ADHD are almost certainly due to wiring, strength of connections between different areas of the brain that are different than in the general population. And while there may be some rewiring that comes about, that's a slow process, and we're probably not clear on how to redo it precisely. There may be more benefit in the long term from some video games or other biofeedback approaches, although the whole neurofeedback approach has not overwhelmingly shown to be helpful yet in ADHD. Anyway, so one is we don't completely understand what's going on with ADHD, and 2, given that it's primarily a wiring and not just a neurochemical problem, that makes it somewhat harder to cure. If it were just a deficit of dopamine, then yes, a bunch of dopamine would cure it. And then the third talk was the interaction between narcissism and ADHD, and the two can look a lot alike, and we know that people with ADHD are more likely than those in the general population to display narcissistic personality disorder. On the other hand, people with ADHD are also very close to the top of the list of people who are likely to be accused of being narcissists when they are not being narcissists. And this is really crude oversimplification, but a narcissist's intent motivation has to be harming, ignoring, doing badly unto others because they do not care about the other person's feelings, whereas some of the similar behavior may come from someone with ADHD out of obliviousness. They're just not aware of what they're doing having an impact on others. And that's, I would argue, an important distinction. So those are the 3 videos. Questions can be on those topics or any other topics. And one other shout out to the Reddit under Dr. John Kruse, DrJohnKruse, is up, and Max has posted many of the video links there. So for some people, it's easier to navigate on Reddit than on YouTube, and it's probably an easier forum for exchange of communication. But if this is working, that's fine. And I do see that there are some questions here already. So good morning, Dennis, or I guess evening your time. Dennis asks, can psychiatrists use dream interpretation as a psychoanalytic tool? Because in theory, dreams aren't contaminated with ego defenses. So they certainly can use it, whether they're using it effectively or in a meaningful way that reflects neurobiology. So there's still a multitude of views as to what dreams really entail. I think, and Matthew Walker summarizes it very nicely in his book, Why Do We Sleep? I believe is the title. So Matthew Walker, he has some evidence which I think is fairly compelling and consistent with a lot of clinical evidence that that dreaming is not just artifact or noise. There are still some people, and Alan Hobson at, if I say Harvard, I think it's Harvard, for years promoted, and this is an oversimplification, the idea dreams are simply random noise generated by our brain when we're sleeping and things are partly disconnected, and any storyline we create is simply reconstructing or trying to sew those bits of random data together to make a story. On the other extreme, there are societies, cultures, and maybe some in the psychoanalytic field that believe that dreams are prophecies, that they are reflecting some absolute truth in the world out there. So the Matthew Walker, and if I'm oversimplifying his approach, I'm going to apologize, but I think he has some good evidence that dreaming, and we're talking about dreams that are occurring primarily during REM sleep. So those are the episodic, often personal-based, sort of bizarre, colorful storyline dreams. There are other states of dreaming that occur during other states of sleep, but those are more disconnected, non-narrative sort of sensations, feelings. Anyway, the Matthew Walker and others have contributed to this. It's not just him. Approach is that dreams, that what's happening during REM sleep is we are trying to consolidate or incorporate the events of the day and put them into a framework that makes sense to how to approach, adapt, live in this world. And that the dream isn't just an artifact of that, but the dream is an active, necessary component of that. And that actually fits really well with the approach to nightmares called, I'm forgetting what it's called. I call it reimagining dreams, where you actively can reshape dreams in your waking life, and that helps resolve whatever conflict, problem, emotional trauma was going on in the dream, and then usually gets rid of having a nightmare. So lots of, the Jungians are the most famous probably, but certainly the Freudians for having an emphasis on dreams. My own bias or approach, and it again fits well with sort of the Matthew Walker approach, is rather than looking at symbolism like any house or building represents the ego or self, I think there's some that seems to track or make some sense. It's hard to verify or scientifically study, but my approach sort of psychodynamically to looking at dreams is to focus on what's the emotional theme, what's going on there, what's the conflict, what emotions are coming up. Often people focus on the narrative, the exciting, was your brother-in-law you were sleeping with and why they had 3 heads or something like that. But that information might be important, but if you're really enjoying the dream, that's one thing. If you're really horrified at that dream, that's a completely different dream. So I think paying attention to the emotional content is the most effective, helpful way for exploring what dreams are about. So that's my answer about dreaming. I see there's a bunch more questions. Hi, Becca. I do want to, before I go too much further, there were some written comments on narcissism that I do want to clarify. So in my talk, I said that narcissism is widely overdiagnosed. And by that, I'm meaning in our current culture, the term is thrown around extremely loosely, usually taken so broadly to mean anyone who's hurt me or done anything that I feel bad about must be a narcissist abusing me. Now, I'm not denying there are narcissists out there. They're even in important places in government right now, that are hurting people and doing it expressly because they don't seem to care about other people's feelings, or humanity. But so again, I think it's widely overused and overdiagnosed in colloquial conversation. At the same time, I would agree that it's probably underdiagnosed in a strictly clinical setting, primarily because narcissists don't think anything's wrong with them. I mean, deep down they do. They fear it. They're terrified of it. That's why they have to tear everyone else down and puff themselves up so big. But they are among the most reluctant group to show up in therapy clinics or go around seeking therapy themselves. Again, part of the deficit in narcissism is a lack of empathy for others or caring about the implications of your actions. So in that sense, yes, it's probably wildly underdiagnosed. The other interesting thing, this is an aside, but when I was in training and still, I think in the modern world, among our personality disorders, borderline personality disorder, and I do think it describes a legitimate and coherent set of symptomatology, was considered the most impaired, disturbed, worst prognosis diagnoses, and particularly some of the psychodynamic theorists felt that narcissism was a less extreme, less damaged personality structure. And yet, in my experience, and others have written about this as well, for many individuals, receiving a diagnosis of a borderline personality disorder is often tremendously helpful. And in that, even though, yes, there is unfortunately some pejorative stigma attached to it, but understanding that what I am experiencing is something other people also experience, that we have names for it, we have some approaches for dealing with it, is a ray of hope. Whereas, again, telling a narcissist that they have a narcissistic personality disorder and they just want you to confirm that everyone around them is a horrible failure and a stupid idiot and a moron and a loser. So I've seen more often people with narcissistic personality disorders flee treatment when they receive that as a diagnosis, whereas borderline people embracing it to some extent as a useful construct. So Becca's asking, is it narcissistic personality disorder or egocentrism? So narcissism is, other commentators point out, some amount of narcissism is healthy, that we having some regard for yourself, some having positive regard for yourself, makes it more likely you will act in ways that continue to ensure that you are safe and secure and thriving in the world. It's only when it becomes excessive and that it's harming other people and harming your interactions and connections with other people that we define it as a personality disorder. And there's whole discussions we could have about personality disorders and how we diagnose them and whether we should diagnose them and whether they're all one big personality disorder with different types of traits. Anyway, so egocentrism would be putting yourself at the center of things. So again, there are certainly people with ADHD who do meet full criteria for NPD, narcissistic personality disorder. And again, that number is actually disproportionately high compared to the general population. There's a striking resemblance between positive illusory bias. I have a video on that, which has mostly been diagnosed in kids, mostly boys with ADHD, where they have unrealistically high assessments of themselves and assessments that are not altered by negative feedback, that they're not that great, and that their own positive assessment doesn't motivate them to work harder to achieve what they think they're already achieving. So there almost certainly are both biological and situational factors which encourage the development of a narcissistic personality disorder. So I'm not sure if I've answered or made a distinction between NPD and egocentrism, but maybe someone will follow up if they want to hear me pontificate more on that. So Max Flynna is saying, hello, by considering personality as a realm of medicine, are we not running the danger of pathologizing every behavior? If all you have is a hammer, everything looks like a nail. So the DSM, which is our standard diagnostic manual for diagnosing mental disorders. I mean, decades ago, they differentiated what were called axis 1 disorders, which were thought to have at least some large biological component, things like depression, schizophrenia, anxiety disorders, from axis 2, which were considered personality disorders, and in the early days were thought to be primarily shaped by psychological factors, interaction with your family of origin. The more we've looked at it, the more it's clear that personality disorders do have a strong genetic component to them. Part of it, again, is that everything that humans do has both nature and nurture intertwined. And so it's not just a simple distinct, some mental health conditions are biological and some are psychological. And there seems to be continuity between some of the personality disorders and some of the axis 1 disorders. So the guideposts or the guidelines for not pathologizing everything is defining things as they are only diseases if they are causing certain impairment in functions that the society deems normal individuals should be able to accomplish, and or they're causing significant distress to either the person involved, or this is not explicitly in DSM, but I would include significant distress to everyone around them. So some of the personality disorders, ADHD itself is, at least in some individuals, a condition that can often inflict more distress, more damage even to the people around than the person who has it. Certainly not always. And there are ways to try to make it make it objective rather than subjective. What is harm? What is lack of function? But yes, one of the common criticisms of psychiatry in general is that we pathologize normal behavior. But again, if you define it as impairments, and again, that is in contrast to your society. So we can have societies that are impaired themselves. And one could argue that a measure of the healthiness of society is how well they can incorporate the range of diversity along whatever axis they're looking at, and garner some positive input from all members of society. So Borislav is asking, if a person doesn't care about taking a dog for a walk, can be related to a certain degree of autism, kind of extremely low empathy. Thank you in advance. So what's really tricky is it's fairly simple to observe behavior. So you can decide, yes, most dogs, even little lap dogs, like to go out for walks, need walks for their health and physical and their mental well-being. Neglecting to do that, the behavior can be observed, measured, problematic. The difficulty then comes to, why is a person not walking a dog they have custodianship over? And it could be a whole range of things. It could be they really care and they want to, but their job is on the line and they're about to be fired and they have 3 human kids to take care of that they are prioritizing at that moment. It could be that they are so busy with the video game they're having fun with that it's hard to pull them away from that. So there could be an ADHD related reason. It could be a narcissistic reason that, yeah, they know the dog needs to walk, but damn it, it should walk itself if it really needs it. And I'm in the middle of a big deal on the phone and I'm not going to interrupt myself for the next 3 hours to do it. It could be something on the autism spectrum where it's harder to appreciate or relate to the needs of the social communication of the dog. So when I'm working clinically with patients, I usually help them focus on the behaviors and deciding whether the behavior itself is acceptable for them if they're in a relationship with this person. So if someone keeps cutting you off in conversation and you've tried to point it out and they don't correct it, at some level, I would argue it may not matter whether it's from ADHD or narcissism or something else or autism. If that isn't tolerable to you, it's fine for you to say, okay, from my end of it, this isn't good or working. I don't want more of this. So I'm leaving. Without getting into, particularly with the details of each example, whether they were doing it because they didn't care, whether they were trying to hurt you, whether they were too stupid and oblivious, X, Y, or Z. On the other hand, I would agree that motivations do matter. I mean, in a legal sense, they matter. If you kill someone with your car, it matters tremendously whether they just dashed out in front of you and it was difficult conditions and you had no realistic likelihood of seeing them or stopping in time, in which case we label it an accident, or whether you had a little much to drink or you were angry from your day at work and weren't paying attention and you probably should or could have seen them and stopped in time, and we might call it manslaughter, versus you see your arch enemy crossing the street and you gun your engine and potentially aim your car at them and run them over, which could be first-degree murder. So I'm not saying motivations shouldn't matter at all. It's just that we get into difficult territory trying to assume we know what the motivations of others are. And this is particularly pertinent. I've written about certain presidents and their mental health diagnoses, and many people, particularly early on, were jumping up and down that a certain president was clearly a narcissist. And I still would point out that much of their behavior is also explainable by ADHD as being oblivious or deciding this is not, again, people with ADHD tend to be interest-driven rather than importance-driven. So he could decide, this is not interesting to me. I'm not going to take care of it or work towards solving this, rather than assuming it's narcissist, that he's really thought about it and he really doesn't care at all about what harm he might be inflicting. And some people defended making a diagnosis of narcissism because they said the DSM definition is based entirely on behaviors. For ADHD, that is a true statement. The DSM 18 symptoms are based in behavior. For the personality disorder, their diagnoses, they are behaviors in the context of a motivating principle. So someone is doing X, Y, or Z because they don't care about the feelings of others, because they're so full of themselves or feeling weak and unempowered. So there's narcissism can display in different ways. So Becca's getting back to, I guess, the narcissism question. Definitely obliviousness combined with impulsivity can make someone appear egocentric or self-absorbed. Next, taking, yeah. So again, it can be hard to sort out what's ADHD, what's narcissism, what's obliviousness, what's impulsivity, what's less awareness of personal space. a whole host of things make it difficult to sort out. Not impossible. So actually, to read the names, I need to put a Ramtin Yahandada, and sorry if I'm butchering the name. How does the effect size for combination therapy with methylphenidate and atomoxetine compare with amphetamines? So, in an Australian viewer made me aware of, there's a site, and I'm forgetting what it's called, but all it does is lists pages and pages of effect sizes for different ADHD treatments. And effect size is a scientific or statistical way to try to get a valid comparison between the magnitude of benefits for different treatments. The difficulty, and when I started reading the question, I thought you're talking about sample size rather than effect size. So one of my I have not looked at the site in great detail. I think there's useful information there. But the difficulty of interpreting effect sizes is that if you have studies that were done on different sample sizes, if you have studies that were done with different populations, if you have studies that were done with different assessment methodologies, the size of the effect is going to depend on those or the apparent size of the effect. And if you're comparing numbers, it's not always a useful or valid cross measure. It gives you some ballpark general information. And again, I don't want to pick on this site because I think there is good information. But another thing I noticed, for some treatments, they listed an average from meta-analyses. And then they also listed some large, individual studies that had been done. And in a couple instances, the average size was considerably larger than any of the individual studies that were done, which I would argue should make you question the validity of using effect size as a completely gold standard for how good and how much of a benefit some treatment is providing. So I would say that there is not a lot of head-to-head rigorous study comparing amphetamine stimulant-based products versus methylphenidate and Strattera atomoxetine combinations. From what I've seen, even the combinations together still don't reach the effect sizes seen with some of the studies on amphetamine-based products. That's how I would grossly oversimplify things. Yes, so that's Cupcake, Mr. Cupcake in the background there. He'll be 14 in 2 months. And so a follow-up question, is there a significant additive cardiovascular impact in combination therapy with methylphenidate and atomoxetine? I'm particularly concerned about the effect on heart rate. So both of those drugs, and it's primarily primarily norepinephrine effects rather than dopamine effects. One is that there is a lot of individual variability. So when we say either methylphenidate or atomoxetine, on average, only boosts heart rate 1, 2, 3 points, only boosts blood pressure a few points of systolically. If you look at the data, though, the vast majority of people don't seem to have any impact, and maybe 20% of people are having increases of 5, 10 points or even more. So one is there's a huge individual variability. Two is, even though we can quantify it more than we can quantify some of our psychological variables, blood pressure is not a thing. It's a continuously varying physiologic variable. So whether you're sitting or standing, how long you've been sitting or standing, when you last ate, what time of day, it shows a circadian rhythm. There's all sorts of, it can be different in your left arm or your right arm, or whether you're holding your arm above your head or at chest level. So even though we can put a number on it and sort of assign a value, we over fetishize numbers. So anyway, getting back to the question, if you are susceptible to blood pressure increases from one, you are probably more likely to susceptible to blood increases from another non-stimulant. But not always. Some people have blood pressure effects from one agent and not another for not completely clear reasons, and the effects are at least additive, whether they're more than additive. So if you're on two of these agents, yes, your risk is higher. But again, that still evidence would suggest that the majority of people, particularly if we're just talking heart rate and not longer term cardiovascular implications, that heart rate for most people is not dramatically elevated, or not even, I would say, clinically significantly elevated for most people. So Max is forwarding a question from the Reddit strand from Turek995 and asks if there's consensus on switching ADHD medications, e.g., for example, switching from duloxetine to a stimulant. I'm not aware of any consensus state. So my question would be, why are we even talking about switching? Presumably we're talking about switching either because someone is not getting benefits from their agent or they're getting adverse effects. And already those are two very different camps or divisions of problems. So rather than give a global answer, my approach there would be the answer is going to be so individualized that it's going to be hard to come up with global consensus statements. So again, I think the evidence is fairly compelling that in terms of efficacy, in terms of the percentage of people who are helped and the extent that ADHD symptoms are resolved, amphetamine-based products do help more people. They help reduce symptoms to a greater extent than do all the others. And I would put methylphenidate maybe at the top of these other drugs, maybe even can call it a non-stimulant. And it's not that there aren't differences among them, but again, if we look at effect sizes, there's sort of amphetamine up here and all the others down below. So, if you're trying to get greater benefit, then there might be some consensus that it does make sense to shift or move to an amphetamine-based product if you've gotten only mediocre results on a methylphenidate or a non-stimulant. The other half of the equation, rather than benefits, is the costs. So I would argue there are some common costs, side effects to all of our agents, but there are some rather uncommon but really, really bad side effects associated with the amphetamine-based products that make them sort of a difficult situation to assess. So higher rates of amphetamine-induced psychosis or psychosis from it, higher rates of addiction potential. So for each individual, the best clinical practice would be trying to assess what we know in terms of likelihood of benefits versus likelihood of bad effects and making recommendations accordingly, and knowing that we don't have any either psychological or biological markers at this point in time that are giving clear, robust indication that one treatment approach is clearly better than others in terms of medication. And I would also take this opportunity to highlight, even though I talk a lot about medication, I am a firm believer that there are extremely few psychological conditions, psychiatric conditions, that the optimal treatment is just tossing a medication at it. I have seen people's depression of years long resolve completely with an antidepressant in a few weeks. I have seen people with ADHD who were not able to hold a job, who became much more functional at work and at home through medications. But I think therapy is, for many people and in most situations, an important element of having a more integrated, fulfilling life, functional life. So, hello, Jonathan. I'm getting back to Borislav. So Borislav says he meant a real hesitation of someone's needs. So he's referring to an extreme low degree of empathy. My mom didn't bother to take a dog for a walk while I was at the university. So again, I don't think it's a good place for me to be a diagnosing, again, based on just the outline of the facts. I mean, it certainly sounds appropriate for you to decide that was not a proper way to treat a dog. I do not want to trust this person with another dog, or maybe even with other people, if her behavior generalizes to other people. Is it possible that it's related to ADHD? Is it possible it's related to depression? Is it possible it's related to autism? Is it possible it's related to narcissism? Without having more data, I could make cases for all of those. It could be combinations of all those. So I'm not sure I hope that's answering or addressing the question. So Becca is voicing her appreciation for the videos, and ADHD has been debilitating for her, but she's glad to have support and glad to have health insurance. So that hopefully that persists in this country, although who knows what will be thrown under the bus next. Borislav is expressing a wish that we had a better understanding of the brain-gut connection, how it affects our brain circuits. And I do have a brief intro video on the gut biome and effects on mental health. There's some tentative suggestions that even with or ADHD is among the conditions that can be influenced. So particularly early on, sort of infant gut biome may influence who develops ADHD. But clearly we are a very long way away, and there are literally thousands of different types of bacteria alone, not just, as well as other microorganisms in our gut. And most of our current ways of assessing are looking at a single place in the gut and a single sample and looking at the most well-known and ubiquitous bacterial components, but that's probably a gross oversimplification of what's really going on in a dynamic ecological way. So yes, Jonathan has asked if they can email me, and I've mentioned the email before. It's drjohnkruse@gmail.com. So yes, I respond to emails, and again, no, I can't make any specific, even with, if you give me more clinical information, I still won't have a doctor-patient relationship with you. So sorry. Ramtin asks, is there any data on the duration of the drug holiday needed for reversing tolerance to stimulants, meaning erasing tolerance enough for a significant reduction in the therapeutic dose? So I have not come across any information. It's interesting because another person asked a related, but I think it was a pretty different question on tolerance or getting over tolerance and how long a drug break or vacation. Again, in my talk on tolerance, my clinical experience seems to accord with most of the ADHD experts and in disagreement with most of the addiction experts. So the addiction experts say everyone develops tolerance to stimulants and does it pretty quickly. Everyone needs to keep going up on dose. What I've seen clinically, and I actually ran the numbers, it's not my impression, it's my actual numbers, is vast proportion, 80+%, continue year after year to be stable on a stable dose, not needing to escalate or de-escalate the dose. Some clearly do need to, and I'm considering that after any initial titration period. So anything I say, so again, there's very little empirical evidence. These drugs all do leave the body fairly quickly. So within a week, I'm not thinking of a single commonly used stimulant or non-stimulant that detectable chain or amounts should be present much after a week. If we argue by analogy, and it's not exactly the same phenomena, but withdrawal from serotonin reuptake inhibitors, so another class of psychoactive medications, primarily acting on indolamines and catecholamines, so serotonin, norepinephrine, and dopamine, and how gradually you have to taper down so to minimize withdrawal reactions in the vast majority of people. Not that some might need even slower, but about 2 months seems to do it. So there, I mean, a very crude by analogy rule of thumb might be 2 months may be an adequate time for some resetting, readjustment of receptors, but that's, I would say that's a very loose rule of thumb. I mean, so for something like alcohol addiction, we know that alcohol leaves the body really quickly. But in people who are chronic alcoholics, we can see brain changes at a gross MRI level that are happening a year out from the start of sobriety. So different systems in the brain can take a longer time to adjust than others. So again, the bottom line is, unfortunately, not a lot of rigorous information. And part of it is that the majority of drug research is still funded by the drug companies. They don't have much incentive to study how long someone needs to be off of something before they can resume it. They want people to keep taking it all the time. So that's a little bit simplistic. Yeah, so Flenna Max asks, how do I approach telling a patient of your diagnosis of NPD, narcissistic personality disorder? With so much stigma around it, I could imagine a lot of patients may take it as an insult, even coming from a doctor. I'd say maybe even particularly coming from a doctor. So one is, I can say that in terms of specific examples I'm thinking of, so one is I have not been taking any new patients for quite some time, and personality disorders, although they could remain latent or hidden or not intrude in the therapeutic process, are likely to show up well before that. So the last time I specifically can recall the example and someone leaving therapy because of it was probably 20 years ago, when some people, I'd say many people, knew the word, but it was not thrown around with nearly the ubiquity it is. And it was, again, not nearly as pejorative, I would say. I mean, it was still, many would have considered an insult. So the general framing is, you're coming to me because you're experiencing some distress or problems. I'm someone who has some familiarity with what can be going on in the brain, or the interaction between your brain and the world that causes these problems. If we understand what's going on, then we have a better chance of changing it, or changing how you work with it to make your life better. And that accurate diagnosis is an important part of that. If we think you're depressed and you're really narcissistic, or it's really borderline personality disorder, or it's really dementia, then giving an antidepressant may not do much good, or even the psychotherapies targeting depression might not do much good. So it's framing it that, again, why I discuss in a couple different videos, and maybe more in my writing, what are the purposes of making a diagnosis? The purposes are, one, to understand, and this is the same in somatic bodily medicine as well as in mental health. One, for an understanding. understanding that this is a pattern of things. It's not just I'm showing up late for work all the time. I'm also distracted here and there. I have ADHD. I don't just have a tardiness problem. And understanding can be both from the doctor treating person's point of view and from the individual themselves. And particularly with mental health conditions, often a significant degree of identification, how we understand ourselves is tied in with what we are doing. So understanding. 2 is predicting. And predicting doesn't mean on Tuesday the 3rd, you will cross the intersection and you'll be 2 seconds slow and a brown Chevy will come by and a man will take your picture and it will go viral. So we're not making predictions of exact specific events. We're making predictions about if this isn't treated, your depression, you're likely to keep staying in bed and being negative and having impact on your sleep and other things. Or if ADHD isn't treated, or making predictions for if it is treated, then this and this are more likely to happen. So they are general predictions about trajectories of life and general predictions about the likelihood of certain types of behavior being repeated again. And then the third reason for making a diagnosis in mental health and the rest of health is to administer specific treatments that we have shown to be effective in that condition. So that's getting back to the framing of how to help someone with a narcissistic personality disorder diagnosis. So Becca's adding to the discussion about the microbiome and volunteering that they have gut issues and severe vitamin D deficiency that just found out about. And vitamin D deficiencies are common enough that it probably should be. I am not a big pusher for getting lots and lots of blood tests. I mean, even though I have more of a scientific background than many of my medical colleagues, I also think maybe because of less knowledge or understanding, or maybe because of American cover your ass from legal lawsuits protection, that we tend to way over order lab tests and sort of are throwing things against the wall to see what sticks. But vitamin D is quite common in our society, even among people who are getting some sunshine and out of doors, even among some people who are drinking milk and eating cheese and getting it in their diet. And vitamin D is implicated in depression and a host of other mental health conditions. So that's my tangent on vitamin D. And Becca is sharing that being on vitamin D consistently has helped in addition to the medication she was on previously. So Max is bringing us back to, are individuals with narcissism more often found in positions of power because of their propensity for using others to further their own goals? So I'm more aware of specific research looking at people with sociopathy, and there is some overlap between narcissism and sociopathy, and low levels of empathy for others are among them. Among sociopathic personality disorders, so among narcissistic personality disorders, this is going to be a gross oversimplification. There are some indications that the person physiologically is registering some distress on the other's part, and they themselves can often be flamboyantly or dramatically physiologically aroused, whereas the sociopaths, and there do seem to be some brain differences as well, tend to be coolly, really detached and are at any level feeling the emotion less and So part of it, and this is, and I'm thinking as I'm talking, so it might be muddled. With the narcissistic behavior, they are actually acting out on their very feelings of rejection, feelings of not being included, feelings of being told they're less than. So it's a reaction within the emotional, relational sphere. They're just doing it in a problematic way. Whereas the sociopath is almost in some ways outside of that realm and can use that realm to exploit other people, but isn't really stirred up by it themselves. That's one dimension of differences. So there are psychologists who have profiled, CEO, Fortune 500 people and found higher levels of sociopathy. I believe narcissism. I'm just not as intimately aware with the specific literature there. So yes, there are ways that being narcissistic, our society rewards it. I mean, most people believe that most politicians of either party are narcissists, some to greater extents than others. And again, narcissism is not a completely bad trait. If you have none of it, you are not able to assert, stick up for, act positively in your own behalf. That wouldn't be good. Yeah, so Becca points out that she has been consistently taking stimulants and that seems to work better than taking breaks to avoid tolerance. So I didn't really address that point. I do have a talk on drug holidays. A frequently made claim for taking the weekends off or taking other fairly frequent breaks from stimulants is that will help make it less likely that someone develops tolerance. I don't believe I've seen a single study that systematically tried to study that asked some group of individuals to specifically take frequent breaks and the other not, and to see if there was a difference in the average dose they wound up taking over time or changes in dose. So there's some logic, there's some basic neuroscience that makes that an appealing thought, but I'm not aware of any actual clinical studies that would verify or support that it's really true or valid. So ultra paradoxical says, I like the name. Hi, Dr. Kruse. Do I have any thoughts about the biomarker HRV heart rate variability vis-a-vis ADHD? With some fitness tracking, you can track HRV. So HRV, or heart rate variability, is the most commonly used marker to indicate whether someone's in primarily a parasympathetic state or a sympathetic state. So our sympathetic state is our alert fight or flight system most of us are familiar with, adrenaline based, that makes us alert, more oriented, an extreme level, full-blown panic attack. Our body's in a constant flux between that system having predominance and the parasympathetic, which is our rest and digest system, which shunts blood preferentially away from muscles to the digestive system, slows heart rate, and slows breathing, calms us down. But not only does it slow heart rate, it changes the variability in our heart rate. And strangely to some people, that the healthiest people don't have a completely stable, unvarying like a metronome heart rate. They have slight variations in their heart rate. So low heart rate variability is a sign of poor health and often suggests low parasympathetic tone. And there are some So heart rate monitors can measure that. There are some studies that have correlated more sympathetic overdrive, lower HRV among people with ADHD. Again, some of this, when we make a global statement like that, the important questions are, what are they doing when they're being monitored? What's going on? What's the setting? What tasks are they being assigned? Mr. Cupcake's making some snoring noises right now. So my experience with sort of monitoring people's heart rates and using watches is more in the setting of people who have panic attacks. And there's just been so many instances where I've seen it be counterproductive. So people knowing that when they're panicked, their heart rate goes up. Again, this is heart rate, not heart rate variability, but getting freaked out about fairly normal changes in their heart rate, which they're interpreting as I'm about to have a panic attack, or which actually trigger the panic attack then. So I would say it depends what you're trying to use it for or do with it in terms. So if I met someone who's found a good use for measuring heart rate variability in terms of treating or working with their ADHD, I would say so far, no. Can I envision how it could be helpful? Maybe, but I'd need to sit and think and can't answer that one off the top of my head. So Becca, again, is making the case for if you're feeling tired, checking out vitamin D and probably B vitamins as well, because that can add to fatigue and or depression and make someone listless. So Ultra Paradoxical says their HRV is very low, wondering whether this is common in ADHD. So I think I answered that. You probably tucked it in before I got to it. There is a correlation with lower HRV and people with ADHD, and the thinking or surmising is that ADHD, whether it's because people are sort of craving more stimulation or seeking or getting it or creating situations where they're receiving more stimulation, tends to be a state of sympathetic over arousal. So my thought there, if you're concerned about it, I would try just a minute of cyclic sighing. I have a video. It's a breathing technique. Really quickly, it's inhaling a breath and a half through the nose quickly, exhaling through the mouth slowly for a count of 4, 5, 6. No pausing in between inhale or exhale or inhale and going back to it again. So is a very effective way at engaging the parasympathetic nervous system. So I would say play around with that and see if that helps increase HRV. And there's some evidence that even as little as 5 minutes of practice of cyclic sighing a day may help reset some balance between parasympathetic and sympathetic nervous system, in addition to the immediately being a switch into the parasympathetic state. So Kooks says, hello, Dr. Kruse. My daughter has recently been diagnosed with ADHD. Is there a possibility that I may have this myself and that perhaps it was passed down onto my daughter? So I have a minute left. So the simple answer is yes. Part of how ADHD was finally discovered in adults was that so many adults were late picking up their kids at ADHD clinics, were forgetting to refill prescriptions, were displaying ADHD traits that finally clinicians and researchers have said, hey, look, people don't outgrow ADHD, or at least many don't, and it seems to run in families. So there is a strong genetic component. That doesn't mean you have to have it if your kid has it, but you're substantially more likely than the general population. So, yeah. So Tanner's comment is modafinil, I would expect to be less likely to trigger anxiety than would Wellbutrin or atomoxetine or stimulant medication. So it has less direct norepinephrine activation. I mean, it's activating more probably the orexin system, which is probably a milder, gentler way to be aroused than norepinephrine. So thanks for the great questions. I will be back next Tuesday, same time, same place. And stay healthy, stay happy, and I'll be back next week.